since we have these health professionals right here, why don't we just dive in and talk about a big thing for caregivers, and that's in the context of caregiving in the health system, right? There's some big issues there. It's about what nurses sometimes think of caregivers. It's about discharging people quicker and sicker, and the caregiver is supposed to be a doctor and a nurse themselves. Big issues here. Do you want to start, Robyn, and then?
Sure. Well, I'm always surprised and shocked and concerned when I hear of caregivers who sit in physicians' offices, because the place to catch the invisible caregiver is either in a church basement or where you're doing some of that, Dr. Woodson, as well as in the healthcare system. Because many caregivers don't, even though we have a wonderful crowd today, they don't say, I'm a caregiver. So it's really important that we create a safety net to find them in other places. And I'm always concerned when I hear a caregiver, a daughter, a son, a niece, a nephew, a spouse will sit in a physician's office time and time again, sometimes the same physician's office, waiting for that appointment, going in with that appointment, and no one ever asks he, or typically she, how she's doing. When was your last medical workup? How's your health? How are you doing? How are you feeling? That doesn't happen. They really, truly, even when they are in that role and seen by others, are invisible in another sort of way. Once you get into a hospital arrangement, sometimes, which does occur very often in the very rushed aspect of healthcare nowadays, I don't mean rush where I work, but the rush system, how fast people leave quicker and sicker, as you said. It is so difficult sometimes to for healthcare providers to engage the family as partners. And as a result, the caregivers often seem like they're not wanted around the bedside, or they're not wanted in a team discussion, or more and more hospitals, in an attempt to reduce their length of stay, are talking about things like discharge lounges. And I was reading about this notion that too often family members don't pick their relatives up in a timely manner, so it means they have to stay longer in the bed in the hospital. And why not create a discharge lounge where people can sit around till their family can pick them up? Well, what concerned me when I heard this was, what about the family needing to hear about the discharge plan, needing to see the teaching that's going on with the patient? How is that going to happen if they're just doing a drive-by pickup? So those are just some of the concerns and the things that we need to be challenged to fix in our system. What about you,
In the new healthcare paradigm, the caregivers are going to have to be the glue, because the communication systems are not there yet. So when you transfer from one facility to another, it's the caregiver who's going to have to be the institutional memory. And there are specific questions to ask, ways to organize that information so that you keep a hold of it. And our caregivers are doing a phenomenal job. And people say, well, it's just one more thing I have to do. But nobody can do it better than you. And there are ways to organize that so that you can ease that transition. And pay for parking, go upstairs, and hear the discharge plan. And there are specific questions to ask.
if they're still on the floor?
If they're still on the floor.
An example of what you might learn if you go pay for parking and go upstairs.
Oh, the medication list at home is different from the medication list that you've just given me. Which one am I supposed to do? Because people will take all of it and end up back in the hospital.
So why would there be two different lists?
Well, if the person got admitted to the hospital and in the course of treating them, changes are made in the medication regimen.
I see.
So that's a simple thing. The other thing is, what do I need to do? This is the ask three. You know, what do I need to do? Why do I need to do it? And what's going to happen if I don't? You know, somebody needs to tell caregivers what the actual need is. And that's what I call level of care prescription.
But first we have to assess whether or not the caregiver has the capacity, the time, the availability to do what we're asking them to do. I can't reinforce enough AARP's report within the last year about home alone. The notion that we're sending family, friends, neighbors home, asking them to do things that, as Dr. Reinhardt, who's sitting in the first row, said to us once, that an RN would be nervous to do on their own, and we're asking caregivers to do some very difficult tasks.
What is the answer?
The answer is to take that teaching time to figure out whether or not the caregiver is the one to be able to create that infusion antibiotic that needs to go on, whatever it is. Are they the one? Do they have to go back to work because they've missed so much work and their job is vulnerable? Or how do we bring in services to compensate? And look at just a greater safety net of services at home that can support the caregiver and not just assume that they're going to be able to do these tasks.
And services at home could be if somebody needs a catheter or if somebody needs...
If somebody needs their medication set up.
Right.
If somebody needs a trip to a transportation to their doctor. It doesn't have to be a heavy physical burden, although sometimes it is. But even the minor things require coordination or people will end up back in the hospital. And, I'm sorry, sometimes you can't get people to do it right because it's right, but you can usually make them do it right for the money. And now that hospitals are going to be penalized for readmissions, I'm hoping that they will help us put some of these strategies into place.
What would be the ideal system that you can create here in Chicago and be a model for the country when it comes to the medical and the health support?
So we're talking about a care coordination system and not waiting. The transitional care emphasis is critical. I'm so glad it's been raised through healthcare reform and the 30-day readmission. Unfortunately, I wish there were more metrics than just that in measuring quality and well-being. Yet, I think if we looked at care coordination across these different silos of systems, whether that be the acute health hospital experience or being in a primary care doctor's office or home and community-based services or even a nursing home. Those are silos of care with rarely coordination or teamwork going on in between the providers and certainly not viewing the patient, the person, and or the family caregiver as part of that team. So that would be a reframe right there.
Right.
I think that's possible. If we don't wait for the crisis, which is what we're doing now, we're putting Band-Aids on tougher solutions than that.